And basically, going to talk about different ways to deal with returning veterans and the kind of stress and trauma that they deal with. And I think it's important to point out that we're essentially going to be looking at the sum of contributions coming from research, experience, and testimony of the veterans themselves. A little bit about me. I went to school fairly late, so I had an experience. I was a veteran, served in the Army Infantry for about 8 years, was a law enforcement officer. That wasn't much different than being working in the Army when I was in. And it was at that point where I decided that I wanted to do something different. I had joined the Army very young, very naive, did the same with law enforcement. Thought that I was going to be a white knight. I was going to go around and save people. That's not what happened in the Army, and that's not what happened in law enforcement. To be perfectly frank, part of what I experienced in law enforcement is I couldn't figure out a clear way to delineate between those that were on one side of the law and those that were on another side of the law, that we seemed to have so much in common. There was just some little thing that made the difference, and usually it had to do somewhat with impulse control, but it also, that impulse control was related to the kind of early experience we had had as well. And if we had had a fairly stable, not great, but fairly stable early childhood, we tended to stay on one side of the line. The others not so much. So after serving in the military and law enforcement and having had my own traumas, I decided that I wanted to work with people who had been traumatized and stressed, and I really started out working with two groups, again, which have so much in common. I started working with first responders, law enforcement, firefighters, EMTs, but I also started working with delinquents and prison inmates as well, and found that they had more in common than they had different. And that's kind of the trajectory that I've had. After I did that for a while, I became a college professor, still am, been doing that for over 40 years, and I enjoy that very much. But I still stay in private practice because that keeps me grounded in reality, I think, more real than being a college professor. And have been very fortunate that the college I work for was originally founded by the Chamber of Commerce in our town with the help of Offutt Air Force Base. So I'm from Nebraska. And when we started a counseling service on campus, one of the things they decided is that we would serve all veterans in our counseling services. So we operate out of the Veterans Service Center, not just veterans who were students, but any veteran who came in off the street. And kind of the impetus for this particular presentation is the number of veterans I've seen over the years who come to us preferentially because they don't seem to get along with the VA so well. And the experience I've had in trying to find out why they didn't get along with the VA so well is what kind of led me in the direction that I've taken, that I'm going to talk about in this presentation. Not that the VA doesn't do a good job. In fact, in Omaha, they do a very good job. Whatever you heard about the VA in some other states, not really happening in Omaha. Yeah, there was some long waiting lists and they got that fixed. But basically, Omaha's done a pretty good job. But there were other things that were going on that I think led to some of the problems. The objectives of this particular presentation, because I do want to go over them specifically, describe the variety of issues and challenges facing veterans returning to their civilian lives, explain some of the common approaches used to assist struggling veterans in the reintegration process, and consider some alternative approaches to providing support to veterans that are not responding to the commonly accepted interventions. And to do that, really think we need to have two requirements. that basically we want to clinically and critically examine the relationships between etiological and phenomenological issues with respect to how this relates to post-traumatic stress, especially with particular attention to the ICD-10, DSM-5 criteria, and then maintain an open attitude towards possibility. Think out of the box a little bit, because I think this has a lot to do with it. One of the most important things that the Army has learned is that PTS doesn't just occur in isolation. And in fact, one of the quotes from a report called Army 2020 is, one of the most important lessons the Army has learned is that many health and disciplinary issues ranging from post-traumatic stress to illicit drug use to suicide are interrelated. To view soldier misconduct in isolation, for example, fails to capture the real likelihood that the misconduct was related to an untreated physical or behavioral health condition, such as increased aggression associated with PTSD or depression. Now that's coming from the Army themselves in 2012. So there has been a real effort in the Army to treat judiciously problems that are brought forth involving discipline, and to treat it in a broader sense, looking at it from both a mental and physical health perspective. I think that is currently reflected in the tendency to use veterans courts, specifically where veterans who were charged with crimes, particularly drug-related crimes, are put through this court that is oriented to their specific needs and is more driven towards rehabilitation and recovery than punitive action. How many of you come from jurisdictions with veteran courts? Apparently none of you. Although some of you may have veteran courts and not know it because some are laying low. Why, I'm not sure. But if you're interested, you just might check with your local county and find out if in fact some of the courts are indeed veterans courts. But veterans then are treated separately. Yes, they're arrested, they're incarcerated. Very often they're incarcerated in veterans units, which are structured along the lines of military training, specific time to get up, physical training, classes, cleanup, looks very much like basic training. And then they go from there to the veterans courts, and again, put into rehab, very structured, putting them along those lines. So kind of get you to think a little bit out of the box about that. Before I do that, though, I want to go back and look at kind of the history of trauma within the military tradition. And it starts out as early as 403 BC. By the way, this is kind of a thing for me. When I first started collecting this information, somebody said it was 603. But I do my research and found off by 200 years. Thucydides wrote in the War of the Peloponnesians about the kinds of combat experiences the Greeks were experiencing. And I thought I'd give you a little of that. They found themselves in a position familiar to all armies, in which fears and strange fancies are bred, especially at night and when moving through enemy territory, with the enemy themselves not far away, and they were thrown into disarray. 406, the war ended in 404. 406 was when Thucydides started to write this. Greek soldiers from that time have had problems. There have been attempts to help soldiers in crisis. Civil War, they referred to cardiorespiratory syndrome or soldier's heart. It's in the medical records. World War I, the first empirical evidence of shell shock, which is what they called it. An early intervention reduces chronic psychiatric disorders, but blast TBI is unrecognized. And if you've ever seen pictures of some of the soldiers identified with shell shock and treated as if it's a psychological condition, it's actually a physiological response with tremors in the muscles, uncoordinated gait, difficulty speaking, things that are more typical of what we now call TBI. Same thing occurred in World War II, combat neurosis or combat fatigue. Early intervention did improve the prognosis. In the 50s to the 70s, there was little improvement, although there were crisis hotlines for suicide and drug use in the civilian world. Nothing was being done in the military world in that particular aspect. Then in 1980, PTSD was added to the DSM-3. That was really big for the military, although it was added in the DSM for civilians. People who had experienced trauma like motor vehicle accidents, physical assault, abuse, rape, things like that. And when they first put it together, one of the things that was really important to them was in criteria A, the idea of there has to be an overwhelming fear, horror, terror that hits you, and as a consequence of that, you begin to experience these other symptoms listed in the other criteria, such as hypervigilance, flashbacks, cognitive changes, and so on. But in their infinite wisdom, since PTSD was better than nothing, the military started using it. Mid-1980s, the impact of critical incident stress and trauma was recognized as a pathogenic factor in all humans, not just warriors, and they began to work with CISM, which is how we all get here for this kind of thing. 1994, the DSM-4 added acute stress disorder. 2000, critical incident stress and trauma intervention expanded into very broadly based comprehensive programs under the rubric of critical incident stress management to provide early prophylactic intervention for everyone, especially first responders and military. What I find paradoxical, but I suppose not expected, or not unexpected, is that CISM was not picked up by the military, I'm going to say until about 2006, somewhere around there, and they're still only doing it, excuse my French, in a half-assed way, but they are using it, and they've been quite pleased with the results, and it has helped some with the reintegration. And at the same time they looked at CISM, they started looking at peer support programs, many of which came from the CISM model. So maybe not directly, but indirectly, CISM has had a major impact. Starting in the 2010s, which is our current decade, if the vet came to the VA with pathological feelings or functions that were manifest and were identified as post-traumatic stress disorder, the treatments of choice were prolonged exposure, cognitive processing therapy, or eye movement desensitization and reprocessing. They became the standard interventions. So standard, in fact, if you go to the VA with PTSD, they're probably going to channel you into one or more of those three interventions. Where I got pulled in is when vets went there and these three interventions didn't work. They either couldn't tolerate them or they simply weren't doing what was needed by the vet. And so in some respects, have to go back and look a little bit about what they're about. When you look at those three interventions, some of them are in response to the diagnosis of PTSD, including the DSM-4 criterion A2, which had to do with horror, terror, and fear. The problem is most vets don't experience horror, terror, or fear to the point where they can't tolerate it. In fact, they're very tolerant of fear in many cases. That's not what the issue is. So despite the continuing improvement intervention, the warriors don't respond, and here I'm asking questions. Maybe they're a unique group of individuals. Maybe the current conceptualization of post-traumatic stress is too limited. Perhaps there are other aspects of trauma or critical incidents that do not readily respond to current rubric interventions. And for sure, traumatic brain injury confounds presentations of signs and symptoms. In previous wars, concussion blast from bombs and artillery typically killed the soldier. Starting with the Operation Iraqi Freedom, Operation Enduring Freedom, body armor had succeeded to the point where many of the concussive blasts that used to be fatal in previous wars were no longer fatal. But the armor, the helmets, were completely inadequate for protecting from blast concussion. And blast concussion, in a head injury, a typical open or closed injury, there's a point of impact. You can see the focal point of impact, and usually you can see what's called a contre-coup injury. Opposite from the point of impact, the brain is kind of bounced on the other side of the skull, so you have identifiable foci of injury on two sides of the skull. In a blast injury, it's kind of like taking Jell-O and just smashing like this. The whole thing compresses, it wiggles around, and in blast injury you get diffuse injury that isn't readily visible through any of our current imaging techniques, but it tends to sever neurons along the interface of the inner brain, the cortex, the inner brain, and a lot of the nerve connections get severed, and it causes rather severe brain injury that's unpredictable in the way it's going to operate because of it's so diffuse. And that seems to be some of what's been going on recently, is that anytime people are on these blast injuries, they're probably going to have traumatic brain injury, but it doesn't show up. And it's pretty hard to test for. You can put them through an entire neuropsychological test battery, but the VA doesn't want to spend the money because it usually takes about 8 hours and it's going to run about $1,200. They're doing those on football players as baselines to see how badly they get concussed throughout their career and can compare, but nothing of the sort's done with the soldiers. And the diffuse brain injury causes a lot of problems: emotional lability, irritability, tendency to be angry, and things like that, along with the other kinds of PTSD that may be going on. The other problem is that warriors are in fact unique. I've got here two columns. One's called battle mind, and the other one's called civilian mind. Anybody here know what a POG is? Person other than grunt. Okay. It turns out that battle mind is a specific training regimen used by the Army, and all the other branches have equivalent training programs. What I think is really interesting is comparing where civilians are educated, socialized to interact, versus where soldiers are trained to interact. And if you will, everybody familiar with Maslow's hierarchy needs? Well, battle mind operates from the lowest level of Maslow's needs, survival and physiological needs. Social life operates in the middle to the top of Maslow's needs. And one of the things in Maslow's theory is when things trump one another, we'll always drop down to the lower level of needs. So under pressure, even if I'm a well-socialized individual, if I'm under threat, I will drop down to lower level needs just in order to survive. Well, in the military, they're trained to do this, and it's reinforced over and over again, and you have secondary operant reinforcement because it keeps you alive. The sheer fact that you do this keeps you alive. They go back to the civilian world, things get bad, they fall back into the mode of behavior that has kept them alive all this time, and it feels comfortable. And so the first thing you see is in battle mind, your closed mouth. You speak tersely, to the point, and you're very uncensored. And I don't know, in the military, the language gets a little rough. So when you're speaking in an uncensored way from the military, obscenity is usually your fallback position. Whereas in the civilian world, you're taught to be very communicative, small talk, you're self-censored, don't say anything that's going to hurt somebody's feelings, certainly don't be rude. In fact, that's one of the problems I think the older generation has with the younger generation, is the younger generation is much more uncensored than the older generation is. But there's a clear comparison, and so imagine the family sitting back home talking, guy comes back from deployment, they want to sit around and small talk, and the girl or guy from deployment doesn't really want to talk, not unless it's about something important. Want to talk about the bills? We'll talk about the bills. I don't care what the neighbor was doing last week. I have no interest whatsoever. Battle mind, you're aggressive and quick. Civilian mind, you're cooperative and relaxed. Well, what does that look like behind the wheel? Okay, well, people kind of driving along at the speed limit, being mellow. Guy back from deployment gets behind the wheel and loses his temper, loses her temper, because people are driving the speed limit and there's places to go, things to do, and I want to be quick about it. There's a disconnect. In battle mind, it's all about control and controlling. I expect to be told what to do. If I'm given the liberty to do what I want, I'm in charge and you'll do what I say. End of story. That way we don't have any conflict. In the civilian world, it's about democracy and sharing. In battle, it's about survival. In civilian world, it's about growth. In battle, you're offensive as is necessary. In civilian, you're defensive. That's the fallback position. Being offensive is rude. In battle mind, it's order, the standard operating protocol. In civilian, it's freedom of choice, and that word, I swear, it still grates me to this day when people say, well, whatever. I don't know why it sends me up a wall. But you don't hear whatever from people out of the military. And they come in, and a lot of things that you'll see is...
what whatever means, right?
Yeah. And there's an order to things. You don't just do whatever. You do specific things. So they come in, the kids' toys are on the floor. Why aren't they picked up? Why aren't they in the toy box? Why isn't the kitchen clean? Why aren't my clothes folded? I still fold my clothes the way I used to fill my foot locker. My wife knows not to waste her time folding my clothes because I'm just going to redo them anyway. Everything in the military is about the team or the tribe. Limited individualism, and the individualism is usually carried out in dress or, dare I use the word, accessorizing? Whereas in the civilian world, everything is about friends, family, and enhanced individualism. There are things I remember from law enforcement and military where I had dear friends who would kill for me and I would kill for them, and they would be the last people in the world I would ever bring home to the family. I didn't want my family to even know these people. But in a pinch, I knew they had my back. And under those circumstances, that's all that matters. Being nice is not what's important. Military often suspicious about people's motivations, cynical, what's going on, looking over their shoulder. Civilians, trusting, and my bad, I still see it that way, perhaps a little naive about what goes on in the world. But Hogue, who was a military army psychiatrist, wrote that PTSD is full of contradictions. Virtually every reaction that mental health professionals label a symptom, and which indeed can cause havoc in your life after returning home from combat, is an essential survival skill in the war zone. So they come back and they have trouble. One of the pros we talk about is how important family is. Well, there's also been some research, and we know that the ability to be close, in touch with people, to relate to people requires a hormone called oxytocin. And we also know that during times of stress, particularly prolonged stress, the body begins to turn off oxytocin. Now that may have a protective factor so that if you have to fight for your life, you don't make the mistake of getting close to your enemy and caring. But people come back from the war zone, the oxytocin is necessary to relate emotionally and close to your family, and you're not producing any. In Israel, they're doing some experimentation with intranasal oxytocin to try and help people overcome that deficit so they can start reattaching to their family after war. But the results are kind of mixed right now. That's where animal therapy becomes so important, because what they found, and I don't know what kind of animal you're into, but they found only 2 animal models that work oxytocin to human, and that's horses and dogs. And it makes it even more important that when the human being excretes oxytocin in reaction to the animal or the dog, the horse or the horse and the dog in turn excrete oxytocin and emotionally bond to the human. So it's a 2-way street, and the human is benefiting from the animal, but the animal is benefiting from the human, and so it becomes kind of a self-fulfilling relationship in which one benefits the other. So animal therapy is probably under-recognized. Being who I am, and when Hogue wrote that about PTSD, the one thing I didn't mention from there is the title of his book is Once a Warrior, Always a Warrior. The problem is, once you've gone through that and it's worked, and if you've been living with it long enough, you start to change permanently. And so you don't magically go from being over here to over here. What you do is you are here all the time, and you learn to adapt your behavior over here. It's like living in a foreign country. So for all intents and purposes, war veterans live in a foreign country the rest of their life. And what they're trying to do is learn the new way of behaving so that they can operate within this new country, have relationships, have fulfilling careers, and things like that. It becomes very, very important. But to recognize that whatever therapy you use, you're learning to live with a new reality, even though you haven't changed, and then ask yourself, step back, does prolonged exposure do that for you? Well, probably not. Does EMDR do that for you? Not sure. Does cognitive processing therapy do that for you? Maybe. But there's no guarantee. You could go through days, weeks, years of sessions and not get anywhere. The problem with EMDR, CPT, and prolonged exposure is they're all time-limited therapies. The assumption is that whatever needs to be done can be done in 12 weeks. My life is now permanently changed. And if you think of 12 weeks fooling around with me is going to change my mindset, the way I see the world, then you're mistaken. It's going to take longer. Now, maybe you could use the same therapies for longer periods of time. Who knows? It might pay off. PTSD is also not monolithic. If you forget criterion A, which says you have to be exposed to something frightening or something else, the rest of it is pretty phenomenological. You have intrusion, avoidance, negative cognition, arousal. It lasts for a period of time. You are in fact impaired, and it's very specific. But we have to remember to kind of piggyback on what you presented earlier, that when you're dealing with criterion A, the nature of the threat is a function of subjective perception and subjective reality. A threat is in the eye of the beholder, and it leads to the possibility that being the subject is not the same as being a witness. You could have different results. Single incidents are not the same as multiple incidents. Perceived threats to life are not the same as perceived threats to limb. Threats to psychological integrity are not less serious than threats to life or limb. Pre-morbid experiences enable resilience and/or vulnerability, and not all PTS becomes PTSD. Next to the last line is super critical. Pre-morbid experiences enable resilience and/or vulnerability. A little-known statistic, and not a statistic that they want to get around, is that more than 25% of new recruits into the military come into the military with pre-morbid conditions. And because of that, they're set up for developing PTS. The military can't not do that. They won't meet the recruitment goals. If they were to admit it, it would be admitting they were recruiting vulnerable individuals. As a consequence, it leads to something that when a vet comes back and is damaged, the VA will only reimburse for those things that went wrong during their enlistment. And if you come in and right off the bat you want to be 100% honest, say, you know, I really got jammed up over there when I was deployed. The hell, that was nothing compared to when I was a kid. Oh, you're fine. And done. No matter how bad it was during deployment, mention that you had a hard time as a kid, you're through. You had a question?
I work with basic trainees on a daily basis. When they're recruited, they have to sign a statement, I have no previous behavioral health history. Either the recruiter will say don't say anything, or the enlisted to be says nothing. That's the number one break. Second break comes at MEPS, where they have to sign something again. We're seeing maybe less than 5% of those soldiers that do come through, and they're being separated from the service for fraudulent enlistment. That sounds bad, but it's a general administrative separation. So we're trying to cover that.
And if it's done successfully with no punitive intent, and there's some kind of recall, we're going to separate you, but we're not going to leave you hanging. We're going to at least guide you in some kind of a career direction. They're doing everybody a service, because it's these same individuals that then get traumatized in combat and then may account for some of what the earlier was referred to as criminal behavior that has to be looked at as not being separate from trauma. And so they can avoid a lot of that. I think the military is trying to cope in realistic ways. So again, I'm not trying to point the finger at them at all. I guess what I'm doing is saying, when you put your life on the line, excuse the crudity, shit happens. It comes with the territory. We as a society that depends upon these people putting their life on the line owe them a debt of trying to help them recover what sanity they can. And that's where the whole thing comes. I'm not here in a position of fault finding. I'm here in a position of trying to help people find what they need and get back to as normal a life as possible with realistic expectations. The families who think their loved ones are going to come back and be just like the person they married are in for a rude awakening. And it's a question of adaptation, and it can be done very, very effectively. Specifically with Criterion A, Dewey, who wrote a book, War and Redemption, he was a military psychiatrist for a number of years. He wrote a chapter called Rules of Fear, and all the rules are not important, but Rule 2 is. Fear does not cause people to break down really as often as broken hearts do. And furthermore, what vets fear the most is breaking the soldier's trust. That what happens in soldiers who are suffering from PTSD or PTS is guilt, loss. I didn't live up to the expectations my buddies had for me. Something I did, and this is rarely true, something I did allowed my friend to get killed. And if I had only been better, if I had only been more responsible, if I had only been more attentive, they would still be alive. And given that choice, better that it was me than them. And so sorrow is more characteristic of PTSD in the military than fear. Not that the military people don't have fear, but it's sort of like fear, what else is new? So what? Of course I'm afraid. You're an idiot if you're not afraid. But I do my job anyway. But if I let my buddy down, if my buddy gets killed, if there's a friendly fire incident, somebody screwed up, and then they feel loss, sorrow, they feel betrayal. Betrayed by other soldiers, betrayed by their words, loose moral system. I mean, I'm not in the business anymore, but I'm not in the business anymore in part because I know myself very well. I was in deployment a really good soldier. I wasn't such a hot civilian, and of course way back in those days, when you apply to go to law enforcement, they say, are you a vet? They stop investigating. They say, oh, you're a vet, sure, to give you extra points and you get in. Somebody asked me when I was in law enforcement, what's your mission in law enforcement? And we didn't have a lot of training. And I said, my mission in law enforcement is to close with and destroy the enemy. I said, no, that was your mission in the military. What's in law enforcement? It's not the same thing? No, it's to protect and serve. Oh, horseshit. I want out of this chicken outfit. You know, it was very, very difficult for me to do that. In part, there's still part of me that's like that because I'm not going to change everything. I've been marked by my experiences. But I do have a good sense of common sense, human decency, self-protection, and I decided since I wanted to help people, and obviously I wasn't being able to do that, I would go into the helping professions. And that's how I got here, and I think that I'm pretty good at it, especially with vets and first responders. But I do remember my first 2 weeks in graduate school having other students come up to me and say, when did you stop being a cop? What do you mean, when did I stop being a cop? You walk, talk, you smell like a cop. I said, I didn't know I was any different, but apparently you learn to kind of swagger or whatever, or maybe it's you're counteracting the weight of the belt on your hips when you walk, or whatever that was. And my freshman instructor came up and said, you know, John, we don't think that you really are suited to work in mental health. Have you thought about engineering or things like that? And I said, yeah, and I really want to do this. He said, well, at the rate you're going, you're not going to make it. And I'm very blunt. I said, I want to do this, come hell or high water. You tell me, and this is the military mind, you tell me what I'm supposed to do, and by God, I'll do it. It'll be great. And with a lot of their help and a lot of commitment on my own, I finally started pulling myself into line and realized that you don't do it by yourself. You develop relationships, and you're able to influence people who want to do things to improve their lives. And I got pretty good at it. But it's kind of funny that if I'm not in my office being professional, if I'm home on my own time, and then something goes wrong, that do it myself, I'm in control, get the hell out of my way and I'll fix it, comes out. And I have to tighter that a little bit when I'm dealing with family, because they made it clear they don't appreciate it, and they remind me, and so I take a deep breath and I become a human being again. But that line's always there, and so I'm very, very aware of it. The precipitants are a little bit different. That when we look at it, normally the expected threat that we're dealing with when we're talking about PTSD, if we don't differentiate between groups, we look at the possibility of death or serious injury, possible or actual sexual violence, witnessing death, serious injury, sexual violence, target intimate relationships. What we don't look at with PTSD is abandonment, betrayal, moral dissonance, injury to self-concept, communal exclusion, helplessness in the face of threat. And I have made it a point that if I see the phenomenology of criteria B through H, I will diagnose PTSD, and the hell with criterion A. And I'll make an argument. They developed all this because of betrayal or whatever. A case I worked on in particular, and I actually won the case. There was an intellectually disabled woman. How it happened, I don't know. She had been working at a big company for 20 years as a file clerk, but she was seriously intellectually disabled. Got a good salary, had a full benefits package. After 20 years, they brought in a new supervisor. New supervisor's attitude was, don't want no retard working in my office. Set her up, fired her. So here she was, intellectually disabled, pretty much unemployable except in a sheltered workshop, but she had been doing really decent work for this company. She has no medical insurance, no guaranteed salary. She's married. She's a primary breadwinner because her husband's intellectually disabled. She went into a full-blown PTSD reaction. Understandable. I mean, she was afraid. There could be serious injury. I could lose everything. I've been abandoned, betrayed. My self-concept's down the tubes. I've been excluded by the main community that I know. I've had friends here at this corporation for 20 years. I feel helpless. And maybe when I die, I'll look back and say that was the reason I lived, was that one case, because I went toe-to-toe and they made an exception. They gave her the diagnosis of PTSD, work acquired, got benefits, disability. But this is what I'm talking when we're talking about how are we going to deal with all the variety of disorders. We have to look at the other betrayals or the other options with vets, and I'm inclined to say that vets will tend to have causes over here more than they're going to have causes over there when you look at PTS. That even when you listen to a vet talk about being blown up, the focus will almost always be on their buddies. I let my buddy down. I should have known better. I should have been able to do something about it. So the expected response to trauma, fear, grief, rage, or anger, more often what I see is enemy, blame, guilt, isolation, loneliness, loss of physical integrity. Vets with PTSD don't just have one or two physical ailments. They typically come in with a list of physical ailments, all of them legitimate, all being very painful, loss of psychological integrity, very often leading to suicidal ideation, meaninglessness, physical pain, shame, spiritual abandonment, premorbid vulnerability, and few or none of those are addressed by EMDR, CPT, or prolonged exposure. So what you would see normally, you go to the VA, you're going to get prolonged exposure, cognitive processing therapy, eye movement desensitization, reprocessing. By the way, anybody big on EMDR here? It works. It's really evidence-based. I only have one beef with EMDR. They haven't been able to prove that it works because of the way they say it works, with the eye movement making all these changes, but that's small potatoes. When you know something works, you stick with it. Yeah.
I use brain spotting, which is one step further on the EMDR spectrum.
Mm-hmm.
And I've, knock on wood, I've never had it not work, never had it not be effective.
So this stuff works. And being a college professor, I always have, it's got to work, and then the explanation about why it works also has to be good. But the fact of the matter, you don't need that, as long as the evidence shows that the thing works.
I think they used to call it originally fucking voodoo.
Yeah. Well, one of the things, and one of our greats in this great program of ours at ICISF, George Everly wrote, that ties into this other side here, regarding treating PTSD. Human beings require explanatory assumptive worldviews or Weltanschauung, which provide order and meaning to the world. They are imperative for mental health. And meaning has got to be dealt with over here. Particularly, I think you can do it in constructive narrative therapy. Adaptive disclosure is tied into that. Some DBT, existential therapy. I had mentioned intranasal oxytocin therapy. Sensory motor psychotherapy. There I'm not going to pretend to be an expert on that at all, but apparently it includes things like yoga and things, has been very, very effective, which is actually going to lead me to something here. And in terms of something else that Breer and Scott mentioned, PTSD sufferers have been shown to have increased rates of back pain, hypertension, arthritis, lung disease, nervous system diseases, circulatory disease, cancer, stroke, digestive disorders, chronic pain, and endocrine disorders, among others. The brain damage, of course, isn't addressed by this either. So far, we're doing nothing on our level. I'm sure that the higher levels in the VA are very concerned about diffuse brain injury coming from concussive explosions. But when it comes down to our level, we're not really getting any of that information in terms of how we can help. We need to make sure that we refer to the VA as much as possible. The VA has a new program. It's called the Whole Health Approach to Treating PTSD. And this was given to me by somebody from the VA, building community for both conventional prevention and treatment, as well as complementary approaches. Mind, body, nutrition, environment. Here's all the things that they offer through these programs. Mindfulness training, meditation, chiropractic, acupuncture, yoga, Tai Chi, Qigong, biofeedback, hypnosis, massage, guided imagery, creative arts, animal-assisted therapy, adaptive sports, aromatherapy, comforting and creating surroundings. It's most accepted by the older vets. The newer vets look at this as kind of mystical and pop BS, which I find interesting. You go to the old timers who tend to be a little gruff and rough around the edges, they're the ones that are most open to this.
But you can use the old timers to get the younger ones to do it.
Yes, you can. That's what they're trying to do, is leverage it.
Because there's a lot of respect between current conflicts and non-Korean War vets, where they look up and say, you know, they had it worse, that kind of stuff. And if you can get your non-vets, your Korean War vets to sort of take a lead in talking to them and encouraging it, they'll go for it.
Yep. So what the Whole Health Program does, it was initiated in March of 2018, so it's just over a year old, at 18 flag sites across the U.S., one of which was lucky enough to me to be Omaha VA, and I met some of the people who are pushing the program. Given funding for 3-year startup, further funding to target identified areas of impact and to integrate the WHP into other VA programs. The focus is on the individual warrior becoming personally active in his or her own care. So it's not just the activity itself, but it's the process of self-involvement, showing up, doing different things. According to an interview I had with A.J. Harris, who is the representative in Omaha, Whole Health is a new approach to providing health care that empowers you to accomplish goals that you create yourself. It focuses on your values and aspirations, recognizes you as a whole person, goes beyond your diagnosis, and one of the complaints I hear from a lot of vets is I'm just a number. and they're trying to reverse it by using much more creative approaches. And I think it'll be somewhat successful, though I'm not overly enthusiastic about a complete change of things. I think it's going to make a difference. The warrior patient can walk into a WHP clinic, just walk in. They don't have to have an appointment, though they like appointments, so they can let them know what's there. They can just walk in, and these activities will cycle through there. And mindfulness training as part of the WHP is being integrated into the what they call PICU, psychiatric intensive care, where people basically get committed for a few days if they're suicidal or things. They're trying to integrate the WHP in with those programs. Yes?
I just happened on this, I was at the counseling conference and did some mindfulness sessions. There's an app that belongs to the Veterans Affairs, VA. It is outstanding.
They are good. The
It
VA
will
has a problem.
It's
Look
called
for VA apps.
mindfulness.
There are about 12 of them.
It's-
and they're
it's
free.
just- well, yeah, it's great.
And
It's great.
Even if you don't use them with your clients, they're really informative for you. So what are we going to learn from all this?
coach.
A PTSD coach, that one's good, and so is the ACT coach that they have too.
And they're designed to be
And concussion coach.
interacted with and used on a weekly or monthly basis. So it always keeps their, and it automatically notifies you, hey, it's time to take a look at this app again. So you're always on top of it.
There's also a concussion coach, since
Yes.
that's by them too.
There's a sleep coach. Like I say, there's about a dozen apps they have. So we're learning an event can be traumatic if it's extremely upsetting or at least temporarily overwhelms the individual's internal resources and produces lasting psychological symptoms. It's solely a treatment issue. We have to separate out the phenomenology of PTSD and the DSM. You meet these boxes, you check them off, you got PTSD, but forget criterion A. Just use B through H. You have all the signs and symptoms of PTSD, you got it. Now let's figure out what the etiology is. So you have to worry about etiology and phenomenology, what caused it. And that's a much more difficult thing. But the nature of the trauma is irrelevant when you're looking at treating. Clinicians treating PTS and PTSD in warriors need to first understand the impact of military service on the mindset of the individual, and second, to master multiple therapeutic methodologies, but with specific loci related to patient experience, or foci. You can't just be a master of one therapeutic or two therapeutic interventions. Not that you can master them in 2 days, but you kind of have to lay out a 10-year plan for yourself. I want to master. What are the good ones? Well, EMDR or prolonged exposure or cognitive processing therapy, but also go after some constructive narrative, go after some relationship, family kinds of things, because it's only with social support that they're going to be able to survive, and social support for them is absolute impossible in the beginning because they're not producing enough oxytocin. But the little research there is on it says if you can get them to try and work over years, they can get back to normal. Get them involved in animal therapy, do things like that. But you're going to have to try some new things. Personal and social integration are key to recovery, both physical and psychological, but symptoms will always interfere with the process, so treatment is key. You're not going to be able to treat a vet in 12 weeks. I don't care what anybody tells you. Vets are long-term commitments. And you may try an intervention that lasts 12 weeks, but that's going to be your first of many interventions. Treatment should be offered in an environment consonant with a warrior experience and preferences. So, I just know I don't want to be politically incorrect. You don't treat a vet in an office that's filled with doilies and little stuffed animals, okay? You find one. I have a preference. I like nature, art, calm tones, things like that make them relax, and they do respond to nature and that kind of thing. I believe those are very useful. Any final comments or questions?